topic on cost effectiveness and artificial intelligence. Now I believe we are online on streaming. So good morning again. Thank you so much for watching this module of our Masters in Cardiovascular Imaging. I'm Fausto Pinto, one of the coordinators of this Masters, together with Professor Almeida, and it's a pleasure again to welcome you all. We have a special session today on cost effectiveness and artificial intelligence. We have some guests and colleagues who will be with us today and will share their knowledge and their experience that will certainly enrich our masters. But without further ado, I will hand over to Professor Almeida, who's going to give the introduction to value-based healthcare. So Anna, please.
Well, first of all, just to compliment everyone, welcome everyone to this session, and also Stefan, who is here, Stefan Peterson. But I will start right with my session that I will do an introduction to this important topic. So just sharing. Oh, I think it's working.
Yeah, all good.
So, okay. So I'll do a brief introduction to this topic. This is a not so well-known topic, and it's very important. First of all, I would like to start with the two seminars papers that were published by Porter. I think Porter is more or less the father of all these concepts, the value-based healthcare. These two papers that were published in the New England 2009 and 10 are basic, and I think I recommend reading them. So, according to Porter's concepts, there is a need of change for lack of a sustainability of trajectory of the health system due to rising costs, an aging population, new medical advances, and there is a need for a central focus on increasing value for patients and for health outcomes achieved per dollar spent. This is the right wording of his proposal. So the only way to truly contain costs in healthcare is to improve outcomes in a value-based system. His basic proposals is that we must have universal delivery of healthcare coverage. This in Europe, it's almost universal, not universal, but almost universal. But other countries like the US, this is not true. So it needs a reviewing and thinking about this. Porter is from Harvard, so many of his thoughts are based on the US. So he proposes also restructuring the care delivery system, and it should be focused on outcomes. Outcomes should be measured over the full cycle of care for a medical condition, not separately for each intervention. Secondly, outcomes should measure survival, degree of health and recovery, time needed for recovery, discomfort of care, and sustainability of recovery. And finally, outcomes should be adjusted for patients' initial conditions. This is a summary of his proposal. So the central goal in healthcare should be value for patients and not for other objectives, not access, volume, convenience, quality, or cost containment. So it should take into account the health outcomes and cost of delivering the outcomes. And unit of analysis for creating of a patient medical condition should take into account the complete cycle of care, from the patient problem, the appropriateness of assessment, the risks, the procedure, the recovery, and finally the final outcomes and costs. So he proposes also in a hierarchy of outcomes, and first of them is the effectiveness of care based on survival and health status, the efficiency of care, time to achieve and short-term consequences, and finally the sustainability of care. So he presented in his paper this. First of all, survival is the basic one, of course, and second, the freedom from disease and functional status, and secondly, time to recovery and time to return to normal activities. So this implies a timely diagnosis and efficacies in treatments, and also difficulty of care related to this, from errors to ineffective care. And finally, the third point important is the sustainability of recovery and health and nature of recurrences. And of course, the most important, we have to take into account the complications from treatments that are also included in the outcomes. So he proposes challenges to organize delivery of prevention, wellness, and screening and routine health services, moving to integrated practice units that encompass all services over the full cycle of care for each medical condition, the need of a sufficient volume of cases of a given medical condition in each center to allow for deeper expertising, integrated teams and facilities, and finally, this is very important, the bundled reimbursement of health centers. And this is important because it's not a blind reimbursement, but is directed to practices dedicated to full care cycles in the medical conditions. And if we think of diabetes, for instance, that is associated with cardiovascular diseases, with the kidney diseases, with many other conditions, complications, we have to take into account that this is a full care cycle that encompasses all the areas that may be related to the primary disease. So a summary solution that is proposed is first of all to have a national strategy in order to ensure value, and this is easier in Europe than in other countries. In the US, I don't think there is first steps, but it's not completely established. Measurement of value, outcomes relative to costs that drives system progress. Outcomes are condition specific and are multidimensional, and costs cover again the full cycle of care. And the only real solution is this, to align everyone in the system around the common goal of doing what's right for patients. Patients are the first objective. And just to show, and we'll see in this session how to do this, measuring outcomes, it's essential. This is an example of what you can take into account: the benefit foregone, the harm suffered, the harm avoided, and the benefit achieved. And we have to do accountability on all the good and the not good outcomes. So of course, most optimal outcome should be to have all benefits and none of the harm. But usually this is not always true, most of the time. So from patient initial condition, we should go to the processes, protocols, quality, safety, compliance, guidelines, all the process of obtaining the best outcome. And for that, we must have staff certification, facility standards, all the good processes, a certified process. Then the output indicators, and finally, the most important, to have the good health outcomes. So this is our last and most important objective. Of course, then the other side is to measuring costs. Costs should be measured around patient's entire cardiac cycle, care cycle against outcomes, and enabling cost reduction. Sometimes it will imply to relocate spending procedures, eliminated non-value adding services, better use the capacity that is available, and shortening cycle time, so to be faster in delivering our treatments and diagnoses. And finally, aligning reimbursement with value, rewards, efficiency in achieving good outcomes, because this is stimulating for all the team, for the hospital, for the patients, for everyone. So this is a very important, and this doesn't happen everywhere. It's not always is taken into account. I'd like to put here some concepts that I think it's important, because when we have a new modality or therapeutics, we must first ensure that they are appropriately used, then to ensure that they are efficacious, they are effective, And the cost effectiveness is very important because it's comparison of incremental value of outcomes versus costs. And finally, the value-based healthcare that takes into account the holistic view of outcomes. So I would like to stress these 4 points. It's patient-centered, so it's personal. Outcomes are evaluated per cost, per dollar. There is a holistic integrated healthcare that we should ensure sustainability of results, and we must have a strong evidence-based decision-making based on the previous parameters that I presented. In a practical way, we should organize multidisciplinary teams around the patient's medical condition, then measure and communicate outcomes by medical condition. This should be published. There should be a number that hospitals and centers and institutes should have. Measure and improve costs by medical condition, and last, develop bundled payments, so specific payments to compensate providers for treating that medical condition. And I would like to show that there is an European direction. This is published into 2020, the EIT Health for Europe. This handbook for pioneers is very useful, and it is directed to the implementation of this value-based healthcare. So I'll just show a few slides on this. They propose an implementation matrix that we have to take into account, considering the condition that identifies a patient group. And first of all, we must mobilize a core team. We see here, we go from this to this point. So mobilizing a core team, involving patients also, defining processes, costs and outcome indicators, enabling data capture, interface, interactions. So we have a data platform where all the data is recorded, benchmarks in order to provide transparent outcome comparisons across providers. This is important also to reduce costs and stimulate competition among the providers. Investments, so to have innovative ways of working, not only ways of working, but new performing way of decision making. Incentives, not only in money, but in resources, many resources, organizing resources, everything. And finally, a learning community that will be good for professionals and for patients. In this important document that is published, I just like to show you some examples, namely this accountability and this assessment allows comparing hospitals' performance for specific conditions. We have here 2 examples of 3 hospitals in the US that shows the death rate for heart failure patients. It's different. We have here the median of expected death rate, and we see that there are differences. This hospital has more 22% of deaths, and payment also is higher for this hospital than the first one. So this must be assessed, thought, and to discover what is wrong, what is the difference between or wrong, or the reason for these differences. Assessing quality of life. This usually is done, of course, in the consultations, so in ambulatory clinic. This is very important for the patient. It's an important outcome. If patients survive and they have not a very important condition, or they recover partially, it's very important to have the quality of life, as we know. And I would like just to show, this is interesting. In Sweden, they adopted this healthcare value-based completely since 2009 or 10. And just to show an example, that for spine surgery, they could reduce the costs per patient about 20% just adopting this new way of organizing health systems. And so, last words for devices and therapies, pharmaceutical medications. So it's advised that suppliers should compete for value for patients. They should be accountable for outcomes and share the risk of their therapies with health services. And of course, there must be in each country regulatory rules that facilitate interaction between suppliers and health centers, but based in this important objective that is to ensure the best outcome for our patients. So in conclusion, I would like to use the EIT health work that present these core principles of value-based healthcare for its wide use in every country. It will contribute to healthcare system and sustainability. It will deliver opportunities for cost savings. It will improve innovation driven by improvement needs and competition, education of professionals and patients, and last, opportunity for business creation because of shift to outcomes-based payments. So small companies can get specialized in some medical conditions and help to improve the outcomes on these patients. So thank you very much. I'll stop sharing. And
thank you, Anna.
happy.
I think that was a very, very good introduction, and we do have time for a couple of questions or comments from our students or whoever would like to comment. Maybe I can start just to warm up a little bit. Of course, this is one area where there's been a lot of discussion, and you just showed nicely the basic principles of. I think we all agree that the value-based healthcare makes a lot of sense, and the big question is how to implement it. And in our country, this has been discussed for quite a while, and there are some examples on some areas and even some places where it's been or started to be implemented. So my question to you is, what do you think are the main barriers for implementing a value-based healthcare program or basis, particularly in a system such as ours, which is basically very much based on the National Health Service? And how do you think we can, first of all, which barriers do you see as the main problems or the main issues to implement a strategy like this one? And how do you see the best ways to implement it and to have in place a real value-based healthcare with, of course, all the advantages that you showed, but also some potential limitations, particularly in the setting of a system such as the one that we have here in our country?
Well, I think there are two areas that we should focus on. First of all, it is to try to develop more widely the creation of a multidisciplinary components for each condition. We are starting to do that. We know that we have a multidisciplinary group for treating, for instance, Marfan patients or diabetics, or we have already groups that are designed and meet and discuss and refer for themselves to take care of those patients. First of all, it is to create that behavior and thoughts in all the community, the medical community. And then I think of course, with that, we can improve surely the outcome of our patients. But second part, if we want to reduce costs, we have to convince the policymakers that this way of looking at the complete healthcare view should be valid for that, and not for now, at least in our hospitals. I think of course, we have the GDH that, of course, it's something that we know that to classify diseases with a group of conditions. Usually they have complications of other areas, and so it's multidisciplinary. But I don't think that reimbursement is paid according to those specific medical conditions. I think we should change the reimbursement of hospitals and centers and the services departments according to these clinical conditions, and to be paid in accordance to the efficiency of their treatment and the increase of outcomes. So we must first demonstrate that those groups of medical conditions work well, and to show the benefit of outcomes, and then ask for not reimbursement in money, but more resources, more professionals to work, to improve, to ensure the results. So I think there is a work to do to convince the policymakers, but first of all, we have to show our numbers accordingly. And maybe you should see what other countries are doing. I think Sweden, Nordic countries are more advanced. I think Holland also, I don't know. UK is also starting, but I would like afterwards to listen to Stefan and Rocco to know what's going on. But there are other countries that are really advanced on that, and we should rely on their experience and work with it.
Very good. Well, certainly it's not the easiest task to implement, and of course one of the big questions, and all the systems that are trying to implement this model is how do you measure value, and how do you measure outcome, and how do you include those parameters into the equation that then will rule the way that it's managed. But at the end, what we want is to have a more efficient way of and appropriate use of the different methods that we have available in healthcare, and to use them on an appropriate way, efficient, and with good result, and cost savings. So that's altogether what it really we're looking for when we have this type of model.
I think we'll have the next sessions will detail this, but I don't know if Stefan wants to say anything, because
yeah, I just want to very briefly say that for cardiac imaging, I think it's really difficult to measure outcomes in a way, because we are often an intermediary and we are not necessarily, as an imaging modality, directly impacting outcomes like heart outcomes, such as quality of life or mortality. We would hope we do, but we have very little evidence that we do. And it depends very much what physicians do with the information we provide to them with the imaging modalities. So I think that's part of the problem. I think it's easier to define process outcomes for cardiovascular imaging rather than how we impact longer term outcomes in patients. So
you're absolutely right. Yeah, go ahead, Anna.
Stefan, could you consider that if you use the appropriate technique, modality, and timely early using or something, could change the outcome of these patients?
I'm convinced that cardiac imaging is really important, and we have an impact on patient management and outcomes. But to disentangle that from the influence the change in management may have, medications on outcome, is really tricky. I think it's easier if you want to do what's the impact of a new hypertensive medication on outcome, or new heart failure medication on outcome. That's much easier to define than what the imaging does, inform the patient, the referring physician, to change management of the patient, and how that then translates into better outcomes. So I think we are sort of, it's really difficult to disentangle, even though I'm convinced, we're all convinced here, that cardiac imaging is really important and has an impact on patient management and outcome.
Yeah, and that's going to be the challenge, is how to measure that, and that's the challenge that we are all facing. But we'll have some time to discuss a little bit more. So, on the interest of time, I think I'll move to to the next presenter, which is Professor Vasco Carneiro, which I can see he's with us already. Tito, are you with us? Very good. So yes. Professor Vasco Carneiro, he's a professor at our medical school. He's a professor of medicine. He's been very much involved in evidence-based medicine and many other aspects of medical education. And it's a great pleasure for me to introduce him. He's going to talk about patient-reported healthcare. So Tito, please go ahead.
Okay. Now, I wasn't. Hold on. Let me just. Okay. Okay. Right, can you see the slides?
Yes, we can.
Yes,
Good.
yes.
No, I wasn't aware that that my talk should be in English. Well, first of all, thank you very much for inviting me. I wasn't fully aware that it was in English. Most of my slides are in English, and then I'll translate the ones that are in Portuguese, which actually are very simple. So I hope that. How many people do we have here that do not speak English?
We have our guests, Antonio. So we have two colleagues that are sharing this session. But feel comfortable and do as you feel, as you wish.
Well, I always like to speak in Portuguese because I can express myself better in Portuguese. Obviously, it's easier for me. But the slides are pretty much straightforward. It's really
no problem. Go ahead. Go ahead.
Ok, então fala em português?
Podes falar em português.
Ok. So, muito obrigado uma vez mais pelo convite. Desculpem, deixem-me ir aqui buscar o. Isso. Pronto. Não sei o que se passa aqui. Só um segundo, desculpem.
Estavas bem.
Agora está bem assim?
Sim, está bem. Assim está bem.
Sim.
Estão a ver?
Estamos a ver bem, podes avançar.
Pronto, agora sim. Portanto, muito obrigado uma vez mais pelo convite. Foi-me pedido falar sobre este título aqui. Value-Based Healthcare e o Patient-Centered Healthcare. E a minha ideia seria talvez combinar os dois conceitos, defini-los primeiro, digamos, individualmente, e depois tentar fazer uma proposta através de um trabalho que temos feito com um grupo internacional de 12 países, precisamente na tentativa de fazer uma fusão entre o Value-Based Healthcare e o Patient-Centered Healthcare. Estas são as minhas traduções para esses conceitos, os cuidados baseados no valor e os cuidados centrados na pessoa, digamos assim, não é? Começo por dizer que não tenho nenhum conflito de interesses para dar esta comunicação, não é? Vamos definir o que são os cuidados baseados no valor e vamos depois falar dos cuidados centrais da pessoa, tentando depois concluir com uma síntese muito simples. Eu tenho depois um paper que escrevemos, aliás, o paper vai ser um relatório que escrevemos, tenho muito gosto em enviar-vos. É um relatório algo complexo de ler, mas que resume bem qual é a conceptualização da tentativa de juntar estes dois conceitos, tão importantes hoje em dia. E depois darei isso no fim, não é? Bom, a definição clássica por Michael Porter daquilo que são os cuidados baseados no valor é uma relação, é um rácio. É um rácio entre os resultados, nós traduzimos outcomes por resultados, os resultados dos doentes e os custos. Portanto, o Value-Based Healthcare é, pura e simplesmente, uma relação entre os resultados e os custos. Okay? Os resultados são inerentemente específicos à doença, são multidimensionais, portanto, tentam captar todo o padecimento, chamemos assim, do doente, e o custo é o ciclo completo de cuidados e não o serviço autónomo. O que eu quero dizer com isto? Que os custos incluem tudo, não são só as medicações, nem só os internamentos, mas também as faltas ao trabalho, os transportes de ambulância, etc. A ideia aqui é captar toda a penalização financeira da atividade médica, da atividade clínica, em relação aos resultados que os doentes nos dizem que são importantes e organizar o sistema à volta destes conceitos, não é? Bom, quais são os problemas com os indicadores habituais? habitualmente, até agora, até há poucos anos, no fundo, o que se entendia era que a qualidade dos cuidados se relacionava intrinsecamente com aquilo que as normas de atenção clínica, habitualmente emitidas por sociedades profissionais, academias, etc., tinham definido. E quando olhávamos para esta realidade, verificávamos que o input dos doentes, isto é, aquilo que os doentes queriam que fosse feito ou desejariam que fosse feito, era muito raro nestes conceitos. Okay? Dado que elas são, acima de tudo, produzidas pelas sociedades profissionais, focam-se, antes do mais e primariamente, na patologia. E a patologia olhando para outcomes muito fixos, outcomes muito facilmente mensuráveis, acima de tudo a mortalidade, resultados objetivos de análise, de imagens, deixando de fora aquilo que se chama o estado funcional. Embora muitas vezes seja que o doente necessita, não é? Que o doente precisa. Estou a dizer que não devemos medir a mortalidade e os resultados objetivos de análise? Claro que não. O que eu estou a dizer é que há aqui um gap. Há um gap nesta abordagem de definir qualitative care contra, basicamente, as guidelines, sem nessas guidelines terem dentro o input dos doentes. E hoje em dia há no mundo inteiro, assim, no mundo mais envolvido em anglo-saxónico, esta tentativa de que é uma tentativa, como digo, muito ambiciosa, por isso é que o Instituto de Saúde Baseada em Evidências está envolvido nela, a tentar criar a tentar ser parceiro de um instituto internacional sobre Patient-Centered Value-Based Healthcare, porque exatamente é isto que está no centro das nossas preocupações. Okay? Estes eram os problemas que nós tínhamos, até porque depois também temos este problema de que cada organização tem o seu próprio sistema de resultados e sistema de medição de resultados. O que implica uma coisa curiosa, porque estes resultados é fundamental que viajem bem de um lado para o outro, não é? Que os outcomes que sejam medidos na Tailândia também se apliquem ao Canadá e os de Angola se apliquem aos Estados Unidos. Ou seja, é fundamental podermos ter um benchmarking para poder, no fundo, comparar, não é? Que é isso aqui a ideia disto tudo, ok? Só para percebermos qual era a realidade até há pouco tempo, esta era, digamos aqui, mostrar aquilo que se chama o Quality Measures List, o National Quality Measures Clinical Analysis, que era, digamos assim, um repositório de medidas de cuidados, no fundo, indicadores de qualidade dos cuidados, e que tinha quase 2.000 variáveis, e, no entanto, apenas tinha 218 outcomes, o resto eram processos, experiência, etc. Apenas tinha 18 outcomes, e desses 18 outcomes, apenas 32 desses 8 outcomes é que era aquilo que os doentes nos diziam que era importante para eles, aquilo que era reputado para eles, aquilo que lhes interessava que fosse tratado. Okay? E, de facto, e tudo isto é altamente complexo, não estamos aqui a dizer que as coisas são simples, não é? São altamente complexos. E aqui vemos os stakeholders que habitualmente têm de estar presentes para poder fazer funcionar um sistema que queremos que seja baseado no valor. O conceito de valor aqui é uma relação entre o que se gasta e o que se consegue resolver em termos dos indicadores que os doentes querem. É esse aqui o conceito de valor. Pelo que temos cuidados de baixo valor e temos cuidados de alto valor. Os de baixo valor são, por exemplo, aqueles sendo muito dispendiosos, pouco trazem ao quadro clínico do doente, pouco ajudam os doentes. Um cuidado de alto valor é aquele que tem um enorme impacto nos outcomes clínicos com um custo relativamente modesto. Um baixo valor pode ser um tipo de cuidados que os médicos não gostam ou que os doentes não querem, ok? Independentemente do preço. Ou seja, há aqui este conceito do valor que é fundamental. E aqui neste slide que eu estou a mostrar é basicamente a complexidade das diversos stakeholders que têm que estar presentes para que a construção de um sistema baseado no valor possa acontecer. Nós estamos convencidos, repito, que no mundo pós-pandémico e depois da brutalidade que foi esta pandemia em termos de gastos na saúde, não é? Acima de tudo, desvio para a pandemia de somas absolutamente colossais de dinheiro, que vão agora faltar cruelmente, não só para a investigação e a inovação, mas também para o próprio funcionamento dos serviços. E estamos, portanto, convencidos que é com uma metodologia destas que nós vamos poder, digamos assim, navegar à vista agora para o futuro, quando quisermos agora retomar e reorganizar os nossos serviços de saúde, que vão ter que ser reorganizados. Disso ninguém tenha dúvidas, não é? Quais são as vantagens? Bom, os doentes deverão poder escolher o local onde querem ser tratados baseado nos resultados esperados. Isto é um bocadinho uma perspectiva de consumidor. As unidades de saúde têm que competir umas com as outras para proporcionar cuidados de qualidade centrados nas necessidades que os doentes dizem que são importantes. Os pagadores terão tendência a negociar contratos baseados em resultados, encorajando, portanto, a inovação neste campo e, finalmente, as tecnologias de saúde deverão demonstrar benefícios em termos de resultados versus custos. E isto é que é das partes mais interessantes disto tudo. É que muitas tecnologias que nós temos hoje em dia são de baixo valor. Custam muito dinheiro para o impacto que têm, não é? Portanto, aqui tem 4 áreas absolutamente essenciais que transformarão, pensamos, a paisagem toda daquilo que são os serviços de saúde. Eu vou-vos dar 3 exemplos muito simples sobre a relação que há entre aquilo que os doentes, os cuidados sentados dos doentes, aquilo que os doentes querem e aquilo que os sistemas dão ou não dão. Cirurgia ortopédica. Como sabem, quando os doentes são operados, depois a seguir há uma abordagem, digamos assim, de medição de resultados no tempo. E este era um estudo com 106 doentes que tinham sido operados a ruptura de ligamentos do joelho e que foram, ao correr do tempo, vem aqui do lado direito, ao correr do tempo, e vão sendo medidos, no fundo, as suas melhorias através destes scores, ok? Através destes scores. E, portanto, havia uma comparação do PROMIS, que era o Patient Reported Outcomes Measurement Information System, com o Gatewright, que é o Temporal Spatial Gait Analysis System, que media, este segundo mede a rapidez, a cadência, a força e outros parâmetros da marcha, que são muito importantes para os doentes numa perspectiva de recuperação da sua cirurgia, que é uma cirurgia muito complexa, como sabem, muito dolorosa, muito limitante, a cirurgia dos joelhos. E, portanto, o que nós vemos aqui é a comparação entre 2 tipos de sistemas, o PROMIS e o Gatewright, em que veem que as curvas são absolutamente semelhantes, não é? Igualmente semelhantes, elas são praticamente iguais, isto é, os doentes vão, em média, recuperando ao correr do tempo. Reparem que o tempo estamos lá ainda assim muitas semanas, mas o que é interessante aqui é que o PROMIS leva 1 minuto a fazer, custa $50, é exatamente igual ao Gatewright, que demora 10 a 15 minutos a fazer e custa $52 mil. Portanto, aqui tem um exemplo de uma tecnologia que vai captar um outcome que é importante para o doente, através de medições relativamente simples. Isto é uma mensagem positiva para não estarmos a pensar que é preciso de sistemas de análise muito complexos. Não, muitas vezes são coisas relativamente simples que captam a realidade igualzinha às coisas mais complexas. Ok? Depois o caso da artrite reumatoide, que é um caso particularmente interessante. Aqui há um par de anos atrás, 3 ou 4 anos atrás, eu estava a apresentar alguns dos nossos trabalhos no campo do Value-Based Healthcare, através do ICHOM, que eu penso que conhece, o International Consortium for Outcomes Management, já vamos falar nisto a seguir. Fiz a minha apresentação em Bruxelas e depois veio ter comigo, na sala em que estava a decorrer a reunião, veio ter comigo um senhor pequenino, em cima de uma cadeira de rodas, e que se virou para mim, eu estava assim do lado, e disse: gostei muito da sua apresentação, isto é muito importante, quem é que era este homem? Ele era o presidente da rede de doentes com artrite reumatoide da Europa. Ou seja, ele era, há uma Federação Europeia de Doentes com artrite reumatoide, e ele era o presidente precisamente dessas dezenas de associações de doentes com artrite reumatoide, que, como sabem, é um modelo muito interessante para testar as qualidades dos cuidados e também os impactos, porque é uma doença crónica de que se morre pouco, apesar de tudo, os doentes com artrite reumatoide grave morrem 1 ou 2 anos em média mais novos que os outros, mais cedo que os outros, mas é acima de tudo uma doença que tem uma qualidade de vida absolutamente dramática em alguns casos, não é? E, portanto, não mata, mas mói e muito. E, portanto, estes doentes são o tipo de modelo, de 2 modelos, o doente crónico, da doença crónica, e da dor crónica, que hoje em dia é uma área também de uma enorme importância. Pois bem, ele virou-se para mim e disse: sabe qual? Nós temos um inquérito entre os doentes aqui da artrite reumatoide na Europa, e concluímos e perguntávamos quais eram as coisas mais importantes para eles. Isto é, na sua vida diária, o que é que era verdadeiramente relevante? E sabe, eu disse: sei, eu sei. Então, a dor de manhã, quando se fala pela dor, não. Bom, então, aquela rigidez, não é? Aquela dificuldade de iniciar o dia, porque as mãos estão muito rígidas, também não. Bom, então se não é a dor nem a rigidez, talvez o cansaço, as pessoas são muito cansados, têm uma astenia muito marcada, também não. Então o que é? Uma boa noite de sono. Eu fiquei a olhar para ele, desculpe, uma boa noite de sono. E eu pensei cá para mim, olha que interessante. Estavam lá 2 CEOs, 2 multinacionais, e com eles: vocês têm algum ensaio clínico de medicamentos que olhem para uma boa noite de sono? Eles não tinham, como é óbvio. Bem, quando cheguei a Portugal, fui fazer aqui uma revisão e o que é que eu fui procurar? Fui procurar exatamente as semelhanças entre aquilo que os clínicos pensam, os investigadores pensam que é importante para os doentes e aquilo que é importante que os doentes dizem que é importante. E depois aqui tem, isto é um paper do Arthritis and Rheumatism Disease, identificando os domínios que do lado esquerdo aquilo que é favorecido pelos profissionais de saúde e pelos investigadores e do lado direito aquilo que é favorecido pelos doentes, ok? Isto é captado em grupos Delphi, dos dois, quer de um, quer do outro, e isto foi aplicado a 125 doentes de 10 países e 108 profissionais de 23 países que classificaram 14 domínios. Pois bem, como podem ver, o tamanho da bola, a importância relativa que tem para um e para o outro. No caso dos doentes, o sono é muito importante, é igual ao distresse emocional, às alterações sistémicas, à fadiga, e do lado esquerdo dos clínicos nem aparece. É que nem aparece. O que é muito interessante. Porque dá-nos a ideia da discrepância brutal que há às vezes entre aquilo que nós pensamos que é importante para os doentes e aquilo que os doentes nos dizem que é importante. E é isto que nós temos lá em linha de conta quando queremos montar um sistema baseado no valor e baseado nas pessoas. Terceiro caso. Este é já do iShow. Como sabem, o cancro da próstata trata-se, a maior parte das vezes, com prostatectomia. Depois há uma série de alternativas terapêuticas, hormonoterapia, quimioterapia, radioterapia, etc. Mas houve este estudo, foi publicado recentemente este estudo, que é um estudo do ISHOM, do tal International Consortium for Health Outcomes Measurement, e que eles foram comparar foram 2 hospitais alemães com um hospital sueco. Ok? Este é um hospital alemão, este é Martini Clinic, um outro hospital alemão, e este é um hospital sueco. Ok? Pronto. E foram, em primeiro lugar, olhar para a taxa de sobrevivência aos 5 anos. E olhando para a taxa de sobrevivência aos 5 anos, os doentes com cancro da próstata, o que significa que não há diferenças. Para os doentes, tanto vale a pena ir a um hospital deste, ou este, é exatamente a mesma coisa. Tudo se altera, no entanto, quando perguntamos aos doentes o que é importante para eles. Claro que a mortalidade é importante, mas aqui não conta, porque se 95 em cada 100 doentes estão vivos, a mortalidade é relativamente menos importante, que ninguém morre disto. Mas quando perguntamos coisas são importantes, eles dizem-nos que a incontinência é extraordinariamente importante e a disfunção sexual também é muitíssimo importante. E aí as coisas é que são interessantes, porque mudam radicalmente. Porque subitamente, quando nós vamos a ver as taxas de incontinência ao ano e as taxas de disfunção sexual ao ano, o que verificamos é que um dos hospitais tem uma taxa que é quase 8 vezes inferior de incontinência e quase menos de metade de disfunção sexual. Portanto, aqui tem uma situação, eu escuso perguntar às pessoas que não estão a ouvir que são homens, se tiverem de ser operados ou algum cancro da próstata, espero bem que não, qual era o hospital onde iriam, não é? E, portanto, isto só é captado porque os promos, os peixes de realidade dos outcomes, estão aqui elevados em linha de conta. Se eu olhasse apenas para a mortalidade, todos os hospitais eram iguais. Não havia nenhuma diferença. E é isto que é importante nesta coisa do value-based healthcare. Vamos agora terminar com os cuidados centrados na pessoa e vou passar rapidamente, que são conceitos que penso que já estão bastante bem definidos nas nossas cabeças, mas que, em primeiro lugar, os profissionais de saúde envolvidos diretamente em cuidados essenciais devem respeitar os desejos e necessidades dos doentes, isto é uma questão deontológica e ética, não tem nada a saber. Devemos perguntar as questões e as opiniões, devemos adaptar os cuidados à pessoa individual por várias razões, a começar da própria literacia que essa pessoa possa ter, até aos seus próprios interesses diferentes no seu contexto social, por exemplo. E depois temos vários domínios da definição daquilo que é o patient centered healthcare. A gestão da doença crónica, a avaliação dos cuidados para além dos resultados, daquilo que já temos estado aqui a falar, e o realinhamento dos incentivos financeiros, ok? O que é isto do patient centered healthcare? É uma tomada de decisão partilhada entre o médico e o doente, com uma preocupação na obtenção de perspectivas do doente em relação aos cuidados, aquilo que nós chamamos de padecimento dos doentes, os próprios, os prémios, etc. Uma visão holística dos cuidados, uma relação respeitadora dos doentes, uma visão integrada dos cuidados com coordenações comuns com outras áreas e, finalmente, uma necessidade que o profissional de saúde tenha um conjunto de características em que ele esteja aberto a esta metodologia, esteja aberto a esta maneira de fazer as coisas. Isto é apenas um exemplo de algumas definições de que nós temos aquilo que se chama os Patient Reported Outcomes, Portanto, há múltiplas definições, não é? Estas são apenas algumas delas, mas a tentativa aqui é que perceber se elas captam ou não captam aquilo que é a tal padecimento, o chamado em inglês illness, que não é bem a mesma coisa que disease. O illness é um padecimento, é a maneira como o doente sente a sua doença, ok? E este é um esquema feito através de estudos feitos em Inglaterra, e no fundo aqui nós estamos aqui a dizer é muito pura e simplesmente que os diversos passos, qual é a informação que nós temos para tratar os doentes, ok? Isto é, o evidence-based medicine, quais são o que temos que levar em linha de conta, depois uma análise do benefício-dano das próprias intervenções, saber quantos doentes é que temos que tratar ou quantos doentes é que podemos lesar com essa própria intervenção, combinando depois isto com os valores e as preferências dos doentes e esperamos, através destas características, que tudo isto seja integrado harmonicamente naquilo que se chama uma decisão de tratamento individual, mas baseada na evidência, ou seja, uma decisão que é centrada no doente, mas que leve em linha de conta os conceitos do valor daquilo que é um sistema de saúde a funcionar, aquilo que é capaz de ter impacto dentro de uma perspectiva holística dos cuidados, ok? Aqui tem um exemplo, por exemplo, de alguns outcomes que são muito importantes. Estou aqui a dar um exemplo, por exemplo, não só na osteopatia, na substituição do joelho, na cirurgia ao joelho, a artroplastia do joelho, que, como estão a ver, é muito importante medir no tempo, seguir no tempo, é crucial seguir. Os outcomes não são apenas para ser medidos no início, são depois para ser medidos prospectivamente durante o tempo. É isso que se capta. O valor do outcome não está no momento da medição inicial, está na maneira como ele se vai modificando no tempo, quer na cirurgia do joelho, quer como já falámos, na cirurgia, na prostatectomia para, por exemplo, cancro da próstata. Portanto, aqui a mensagem é que estes promos têm que ser seguidos durante muito tempo, para tentarmos captar o impacto crónico das nossas intervenções, ok? Isto é apenas um esquema muito simples de qual é o papel desta captação dos dados para o Patient Centered Care e depois, bem entendido, à volta desse conceito, toda uma série de fontes de informação, toda uma série de organizações de serviços, toda uma série de análises de dados, de bases de dados, de registros doentes, por exemplo, etc. Para quê? Para que a gestão do doente individual seja de facto boa e combine de facto os interesses do sistema, está perfeitamente definido o que é que quer fazer, mas também com os doentes, para que os doentes nos possam dizer se estão ou não estão satisfeitos com os cuidados prestados. Termino com a noção que temos estado aqui a falar no fundo, que é a noção de tal estudo que estamos a fazer com estes 12 países. No fundo, é a combinação entre o Value-Based Healthcare, o Patient-Centered Healthcare e a equidade na distribuição de recursos. Este é o relatório que nós escrevemos e que eu terei muito gosto em vos enviar depois, como base para esta nossa conversa. Isto é apenas um dos esquemas que está dentro do relatório. Nós temos 3 análises: micro-level, o nível micro, o nível meso e o nível macro. É uma proposta de transformação dos sistemas. E depois eu termino com a mensagem que é, hoje em dia, uma realidade indiscutível, não é? Isto é, já existem muitos tempos e muitos contextos, os próprios doentes em redes classificam-nos, dizem se gostaram de nós, se estão satisfeitos dos nossos cuidados, e, portanto, uma abordagem estruturada desta realidade só pode ser positiva, até mesmo para nós também, não é? Portanto, aqui tens os meus contatos, se quiserem algum contato. Uma vez mais, muito obrigado pelo gentil convite que tiveram a fazer. Foi um enorme prazer estar aqui. Eu penso ainda por haver um par de minutos para alguma questão que queiram colocar. Muito obrigado.
Muito obrigado, Tito, e muito obrigado por esta excelente apresentação. Me importas fazer a discussão em inglês?
So, sure. I'm sorry. I please be aware that I'm open for questions. Any comments that you may want to do.
Very good. So thank you so much, Tito. We have a couple of minutes for a couple of questions from our students or from our colleagues who are also watching this module today. You showed very nicely, it's illustrated with some nice examples. Of course, one of the key aspects when you assess this methodology is how to select the variables that you're going to look at, and what we already discussed a little bit in the first presentation, how to measure value, how to select the variables and the parameters that can provide more value for value. And that will be a little bit my question to you, if you want to, just give us you actually showed nicely a couple of examples, but how, particularly in some areas where the example of the cancer, the prostate cancer is a very good one. If you look at one parameter, nothing is different. If you look at another parameter, it's totally different. So how to measure outcome is really, and particularly in our setting, we are discussing, we are in the middle of cardiovascular imaging masters. But regardless of that, in your view, what is the best way to identify the parameters that we should be looking at, so we can actually value the value of outcome?
Well, I can give you an example of the ICHOM methodology, the International Consortium for Health Outcomes Measurement, that actually was built out of Harvard on the department of Michael Porter's. Now he's an autonomous academic institution, but it was born there. And the methodology that we follow there, our institute have been reported that what we do is basically we define standard sets. And the standard sets are exactly what you just said. A set of symptoms and wishes that the patients may have for a specific disease. We are responsible to develop standard sets with other people, of course, for arterial hypertension, autism, and we are now just publishing the third one, which is developmental disorders in childhood. I'll give you an example of the hypertension standard set. The way we did it, and we also do this, is first of all do a systematic review on the literature, looking for all the outcomes that have ever been measured, for example, in hypertension. When we did that, we collect about 240 variables. So there were 240 measures that were used in clinical trials, observational studies, anything on hypertension. Then we set up two other things: a group of doctors, experts on the area, a group of managers for the patient registries, and a group of patients that are let's say, significantly same as the standard set will be applied to. And then with the iterative process of several meetings, we start by defining what will be nice to have, perhaps having or not possible to have. And then during about 6 to 7 meetings, we are able to diminish those 240 to around 8 to 10, 12. And those 8 to 10, 12 reflect the methodology of looking at every single outcome that was ever studied in hypertension, and then having the benefit of the healthcare professional input and patient's input. And then we remain with a standard set of about 12 variables, and those 12 variables are the ones that we consider to be, first of all, the most representative of that specific disease. Second of all, the ones that are more commonly mentioned by patients and doctors. And third, one that can be applied in different settings around the world. The idea is that these settings travel well. Again, they can be applied in Thailand, same way they can be applied in Portugal, or they can be applied in Canada.
Okay.
Very good. Thank you so much. And
Antonio, I would like
just to
show, yes, I like very much your presentation.
It's 57, so
this is very important. I would like just to ask you something. I think it's important to have the view of patients, as you said, because it concerns quality of life and recovery of a disease and everything. How do you imagine or propose that we should connect with patients' associations? Should we promote them, and should we have a connection as professionals with them? Because I think it's important to hear their voices.
Well, very quickly, in my view, the modern patient association has 3 goals. Has to have 3 goals. First of all, has to be a lobby for the patients, okay, pressing the authorities and making them aware of disease. Second one is to help the patients themselves to take care of themselves or the carers, whatever. But the third one is very important, is to finance research in that specific disease. And in so doing, yes, I think we have to talk with the patients association and make them partners in this endeavor. In other words, they should be together with us in developing this type of data, and hopefully on a normal and constant way, on a permanent way. We don't want to close the system and say that's it, it's done. No, it's an open system that can be updated every single day. So yes, we can and we should include them. Of course, the problem is to have educated patients that knows a little bit science and that can actually add something of value. But that's a very a challenge, but it's always possible.
Because associations usually have some consultant people that give their advice, and they are professionals, of course, doctors usually. And I think it's important because they can have lots of pressure among the policymakers to get good results and good support for them. Yes, I agree completely. Well, thank you very much, Antonio. I think
thank you.
Thank you very much for your coming. And we'll move next to, I don't know if Rocco is already here.
Yes.
Hello. Hi, Anna. Hi, Fausto.
Hi. How are you?
Rocco.
So I will introduce Rocco. So Professor Rocco Friebel is an assistant professor of health policy and the deputy director of London School of Economics in the health area. He's director also of the Global Surgery Policy Unit at the London School of Economics, and he's very specialized in the economics of health system delivery and the evaluation of complex interventions aiming to improving quality of care. So it's our topic. It's a pleasure for me to be also in the task force of value-based healthcare in the EACVI. The chair is Stephen Peterson, he's here. So we are members of this task force. We are very interested in this. And it is a pleasure to have you here because you are an expert on this topic. Please, the stage is yours.
Excellent. Thank you so much for the kind invitation. It's a real pleasure to be here and talk about something that I'm really fond of and keen to share. And I mean, I just had a quick glimpse to the previous speaker, and I believe it was about the use of systematic reviews, Cochrane collaboration. And I think hopefully by the end of my presentation, you will students and everyone on this call will understand the value of that, of course, but how we actually have to overcome the limitations that are presented by data synthesis, randomized control trials, and how we can move on to derive value and effects from quality improvement initiatives. And I believe I was given 20 minutes or so to give my presentation here today. Yes. And this is usually a topic I could talk about, could talk on for days and days. So this is going to be a really condensed version, but hopefully I'm going to break it down to the key points. So I hope everyone can see my my slides here.
Yes.
Okay, fantastic. Good. Thank you, Anna, for this for the kind introduction as well. Just a brief disclosures. I'm also a scientific advisor to Circle Cardiovascular Imaging Inc., based in Canada. So before I dive into the actual measurement and the methodologies that can be used to derive a causal effect of quality improvement initiatives, interventions, policies that are being implemented in a local healthcare system, in a particular hospital, in your country, nationally or even internationally, I think it would be good to just position this idea of quality improvement within the wider context, and then we break it down step by step. So the reason why we focus on quality in the first place is simple, because we've seen, or research has shown, substantial variation in the quality of care that is being provided within the same hospital, nationally, across hospitals, internationally. We do have significant problems in terms of access and significant cost implications, thinking about out-of-pocket expenditures, all sorts of costing implications that vary significantly. And quality is one of the primary objectives, one of the triple aims of the primary objective of the healthcare system. And any regulation, any initiative, any quality improvement initiative that we observe is in direct response to those triple aims, those challenges that health systems are under. So many of you, I believe, are medical students or with already qualified clinicians or in the process of being qualified. And the thing that you are most familiar with is probably evidence on the efficacy of an intervention. And the question that essentially the efficacy question is about, does a product, an intervention, does it actually work or can it work? And this is tightly linked to the idea of evidence-based medicine, a concept, as you all know, has come up since the late 80s and has really led to an explosion of evidence generation through randomized control trials, synthesized through systematic literature reviews, and they directly feed into the clinical practice guidelines that you are abiding by and that you're learning about. But there are other key questions, because one thing is, just because something works in a very controlled environment conducted by an RCT, it does not work that the findings of the RCT can actually be translated into the effectiveness in the healthcare system. So the question we have to answer, or policymakers will have to answer, is, does the intervention actually work once it's being implemented and rolled out much more widely? Once it's being implemented, there's a costing element. Is it actually worth putting your money, the financial resources we spent on healthcare, focusing on one particular intervention, on a drug, on a treatment? And then finally, the question is about fidelity. How are we doing? Do actually, you as a doctor, as a clinician, do you actually follow the clinical practice guidelines? Are you following what the science says? Are you following what we know is efficacious, effective, and efficient? And I'm going to give a brief example that shows you that very often this is not the case. But essentially what we're trying to do, and this is where quality improvement measurement comes into place, is moving away from this idea of evidence-based medicine. So we're trying to use outcomes research frameworks to understand whether something is effective, whether something is efficient, and whether there's high fidelity, and whether doctors or providers of care are actually doing what they are supposed to be doing. Within the effectiveness element, there's a comparative effectiveness research framework. And of course, that differs a lot from an RCT as well. So in an RCT, you very often just compare one intervention to an outcome. You see if X causes Y. But in reality, if you're in clinical practice, you have to make a decision on potentially 10 different pharmacotherapies. And you have to make a decision on which one is actually the most effective one out of the 10 options available to you. And that can only be done, or is very often done, through comparative effectiveness research. As I mentioned before, quality measurement and quality improvement measurement is really about how are we doing in the healthcare system. And we would specify that as evidence practice gaps. So perhaps there's an overuse or an underuse problem of certain interventions. Once we have identified those evidence practice gaps, we can then develop policies, an improvement program, a quality improvement program that is then a direct response to those evidence practice gaps and are trying to narrow the gap to what we would actually want to see in an ideal world. And that then feeds back into the outcomes research framework. And this is where sort of the effectiveness measurement sits, that I will talk about later in this presentation. So for those of you perhaps a little bit skeptical, I wanted to just highlight to you this one paper, which has been extremely influential by Elizabeth McGlynn in the early 2000s. And what they have done is they have tried to understand what is sort of the fidelity of care provided to patients in the American healthcare system. And of course, this is in the American healthcare system, but trust me, similar problems exist elsewhere. So what they have done is they have identified a random list of patients who have been accessing healthcare services over a period of the past, over the period of 1 year. And they phoned them up and they've asked them, what was your diagnosis and what type of treatments did you actually receive based on that diagnosis? And then they compared the treatments that they received to the clinical practice guidelines, to what they should have actually received. And what they find in this study is that essentially, out of quite a large number of individuals and a large number of potential indicators that they looked at, only about 50%, only half of the American population actually received the care that they should have received, given their diagnosis and their condition. So this was an eye-opening finding. And you might say, of course, this is early 2000s, things will have changed a lot. There has been a follow-up study, of course, not as detailed and as broad as the New England study, but even 10 years, more than 10 years down the line, this study published in JAMA found that similar quality improvement, gaps, evidence practice gaps are still existing even to date. So there is a lot of room for implementing quality improvement initiatives. And in order to come up with with an effective measurement strategy, I think we have to take one side step to just understand, how we define quality of care in healthcare, and then, how we derive measurements for that, and then we can actually use those measurements to, derive or implement some sort of causal inference mechanism. And I think I shared this as one of the essential readings. I mean, this is Arvid Donabedian, who's sort of the father of defining healthcare quality and what we mean by healthcare quality. And it has been a remarkably influential paper in shaping the field of quality measurement and quality improvement. And he sets out in this article, quality is incredibly difficult to measure, depending on who you ask. Everyone will have a different, idea of what they mean by quality. If you're assessing quality from a patient perspective, it might actually be very different from assessing quality from the care provider perspective. You as a doctor, you might value things differently to a patient. But essentially, he goes on in this article saying, quality is a value judgment that applies to several aspects, properties, ingredients, and dimensions of a process called medical care. And he goes on by breaking quality down into 3 elements: structure, processes, and outcomes. Structure pretty much relates to the characteristics of the providers and the systems. So do we actually have the resources in place to provide care to anyone in your healthcare system? Do we have the right number of doctors in place? Do we have the right number of beds in place? What is the infrastructure? Do we have access to medicines? All of those structural elements form a key part. And he believes that, given the proper setting and instrumentalities, good medicine is going to follow automatically. The second element is about processes, and that's about the actual care that is being given to the patients, what you as a health professional do to the people who come through your door. And actually, cardiovascular medicine is a very, has always been a front runner in terms of quality improvement and measurement, partly because in many instances, it is very clear what should actually happen to patients. When should they get a beta blocker? When should they get their ACE inhibitors? And all these, all these tools that have shown to be highly effective in terms of reducing or improving patient outcomes. So processes show whether medicine is properly practiced. And then we have outcomes. And that's, some of you would probably argue that's the ultimate aim of a healthcare system. It's about, improving, we want to improve the outcomes of the patients ultimately. And, outcomes refer to the consequences of the interactions that we observe, the processes that have been put in place. And they are considered the ultimate validator of the effectiveness and quality of healthcare. things have moved on. I mean, Harvest on Obedience, this framework came up in the 1960s, so quite a long time ago. Since then, things have moved on. You know, different institutes, such as the Institute of Medicine here in the US, they defined quality according to 6 dimensions. That was then further adopted by the WHO, by the OECD. Depending on what international organization you look at, there are slight variations in the way they define quality, they assess quality, and but very often these are the 6 aims that you will probably come across very often in the literature. It's about the safety of care, the effectiveness, patient-centeredness, timely, efficient, and equitable. Okay, so now that we know what quality in healthcare means, we have to derive quality indicators. And again, a few things that I picked up from the previous speaker. You know, he just the last 10 minutes that I joined his conversation. You know, you can have hundreds and hundreds of indicators that are being derived from your quality from your literature reviews that are, you know, potentially applicable across different healthcare systems. But there are some key elements that any quality indicator has to abide by in order to be actually a useful indicator, to reflect on the structure, on the processes, or the outcomes of a healthcare system. So to be a good quality indicator, to be used for a robust quality improvement evaluation, the indicator has to be of high relevance. So there has to be an impact, a direct impact, a causal link between whatever happens in the healthcare system, the disease, the risk, on healthcare expenditure. Going back to the triple aims, think about cost implications. The stakeholders, whether it's you as a clinician, whether it's policymakers, patients, anyone involved in care, should be concerned about the quality problem that has the indicator that is being endorsed. And there should be a potential for improvement. Then, in addition to relevance, the quality indicator has to be scientifically sound. That means there has to be a high validity. Does the indicator actually measure what it's supposed to measure? Or is there a lot of noise? Is there a lot of confounding that cannot be controlled? Many other factors that are perhaps influencing that indicator that we can't clear out in our analysis, in our evaluation. Is the indicator sensitive to change? If we play with the system here and there, does it actually get picked up by the indicator? And then, of course, is it reliable? So is this indicator providing us, stable results over time? The third domain refers to the feasibility. And of course, it's great to have all these indicators and ideas of what, in theory, we should measure. But very often, the choice of the indicators boils down to what we can actually measure in the healthcare system. What data do we have available in the healthcare system that we can use to, infer an effect of a quality improvement initiative? And if there are no, if we can't easily derive them from existing administrative hospital data, routinely collected data that is available, is it actually worth going out there and collecting more information by hand? In some instances, that might be, the right thing to do, but of course, it comes with significant cost implications. And then finally, the truthfulness of an indicator, and that's about the comparability across providers, regions, countries, and then of course the user friendliness. Because whatever we do in terms of our evaluation, it's about communicating that to those who are actually working on the ground, those that are seeing the patients, the clinicians, and it's not just me as a health economist sitting in my ivory tower crunching some numbers, but nobody understands what my findings actually mean. So these are the key things when you determine your quality indicators that have to be addressed. So in the next 10 minutes or so, I would like to just specifically highlight some methods of evaluate the effectiveness of a quality improvement initiative. And I mentioned to you, randomized control trials, have been sort of pushing the boundaries of being used, being the foundation of evidence-based medicine, because we want to do what the science says. but at the same time, substantial limitations to control trials, and the job will be aware of those problems. So there are issues with regards to the conduct of the randomized control trial. There are lots of biases that are potentially feeding into randomized control trials, thinking about allocation, concealment, selection problems, the measurement of the outcomes, a huge number of elements that can go wrong in randomized control trials. And when you look at randomized control trials, you'll be perhaps appalled how often things go wrong. And what does that actually mean to the findings of those studies that use randomized control trials? And how do these findings then feed into your clinical practice guidelines? So in turn, on what evidence are you actually basing your clinical decisions? I would argue potentially quite poor evidence. So we have to try and think within that outcomes research framework, how we can shift away from randomized control trials that are costly. There are these biases. Randomized control trials do not necessarily reflect the true clinical population that you would see in your day-to-day practice. So outcomes research and trying to use quasi-experimental study designs on real-world evidence is sort of one way to perhaps not replace randomized control trials, but perhaps complement the research and the findings that comes out of randomized control trials. And what we want to establish across any study methodology is the causal relationship. So we want to know whether one drug leads to an outcome that we're interested in or changes an outcome. We want to know whether a quality improvement initiative, a policy that was being implemented, actually leads to a change in hospital behavior, in outcomes, in processes, in structure. So does X lead to Y without a randomization? That's what we want to achieve with a causal experimental study design. And within the study of causality, there are a few biases we should be aware of. And those biases can be addressed with some study designs, and they cannot be addressed with other study designs. And I think when it comes to then making sense of the findings, it is important to be nuanced and to provide the caveats around the biases. So one particular bias relates to history, for example. So there may be co-occurring events at the same time as your intervention, as your policy. How do we actually take account of that? And to what extent do co-occurring events influence the findings that we have? There's a problem with maturation. And specifically in certain clinical settings, people will get better simply by time. Or patients might get worse simply by time because of age. If you look at childhood epilepsy, for example, many kids just simply improve. So the thing is, if we implement a policy that is targeting children, is the effect that we observe actually down to natural progression, of the child, or is it actually because of the intervention that we're trying to study? Then we have testing and instrumentation, and that's particularly a problem if we send out questionnaires and we ask, patients, physicians to fill out a knowledge test and these sort of things, and people might get sort of savvy and familiar with the instruments, and not necessarily reflecting the true change in behavior. We have regression to the mean, that over time, specifically a problem in quality improvement initiatives that are targeting at sort of outliers. So if we look at patient groups that are potentially high users of A&E services, and we follow those patients over time, very often they might just regress back to what the average of the population looks like. And it's because we identified, or we focus on patients that have been outliers at the outset. We have selection bias and attrition problems. So there are various causal experimental study designs that are worth noting. I put a paper here by Clark, former colleagues of mine, Clark et al., published in the BMJ, that discuss a nice set of causal experimental study designs, methodologies that can be used to, for the study of effects of quality improvement initiatives applied to real-world big data. Examples include regression and discontinuity designs, difference in difference designs, and interrupted time series analysis. And I don't want to go into too much detail with the first two, but I thought, especially as clinicians, focusing on interrupted time series analysis is probably quite an important study methodology, because it is a relatively simple way of analyzing the data. It's easy to understand. It shows you it allows you for a nice visual assessment of the step change, so the immediate change of the intervention on the outcome measure that you're interested in, but also whether this change, whether there has been a sustained change over time. So think about the slope of the outcomes. And then, of course, it protects against most of the threats to the internal validity. So those biases that I outlined here, history, maturations, and so forth. So it's a very strong study design, widely applied. If you study the literature on quality improvement, you will come across it quite frequently. There are some limitations or some points to consider. So the first one is specifically with regards to the observations that have to be available. So usually, in order to do a robust evaluation with using time series analysis, you would look into having between 16 and 20 observation points before and after the intervention. And some statistical tools allow you to use fewer observation points, but essentially the more points you have, the better it is to establish a trend before the intervention occurs, and the more robustness it gives in terms of assessing, really assessing the true impact of your intervention. And then, as I mentioned before, time series analysis can be applied to routinely collect data, procedures, costs, diagnosis, anything that is actually collected in a hospital environment. So let me show you a brief overview of what I mean by this time series analysis. So what we have here is essentially on the y-axis, we plot our outcome, whatever it might be. It could be mortality, for example. Then we have a pre-policy period. We have our intervention at time t, and then we have our after policy intervention. And policy in that sense could refer to a quality improvement initiative. We do establish, we do have a baseline of the outcome. Then we establish our baseline trend before the intervention takes place. And then we observe a step change immediately at the point where the intervention happens. So there's a significant reduction in mortality at the point of the intervention. And then we can see that over time, mortality, for example, decreases even further. Perhaps there has been some learning or further spread of that knowledge, whatever the improvement initiative might be within the system, leading to improvements in outcomes. And what we're assuming is essentially that in the absence of this intervention here at point T, this trend line that we established beforehand would have simply continued. That is sort of the underlying assumption. There would have not been a change in the baseline, and whatever change in the step we observe and in the slope, we can now attribute to the intervention. And then, of course, we can use the difference, let's say at half a year later, between the last point of the baseline trend and sort of the point estimate of the outcome to estimate the overall change at a given time. So this is the key idea of an interrupted time series analysis. And statistically, it's not particularly challenging to implement. So let me give you a brief example to just illustrate to you how interrupted time series analysis has been used to assess the effect of a quality improvement initiative. So this is an initiative that was implemented in the Massachusetts General Hospital in the United States, and the intervention aimed at ensuring that TTEs are appropriately used according to certain criteria or guidelines. And what they have done in their local setting is essentially they provided every clinician who's within that particular aspect of care with a lecture of what the appropriateness use criteria look like, for TTE. They provided them with a pocket card, which allows them to essentially refresh their knowledge on appropriate use, from time to time. And then they send them bi-weekly email feedback regarding the ordering behavior. So a very much a quality improvement initiative that is very much integrated within a local hospital system. And you can imagine, doing a full-blown randomized control trial here, to understand the knowledge or the value of a few lectures or pocket cards might be a little bit of an overkill, actually. So doing a interrupted time series analysis proved to be the most, suitable, appropriate way of assessing the effectiveness of that intervention. And so this is taken from, so the paper was published, I think, in JAMA. And essentially what it shows you here on these graphs is, in the green line, the pre-intervention period, in the blue, in the red charts, bars, you can see the post-intervention period, and on a number of indicators that were of interest to the researchers. So the number of TTEs, and then the inappropriate ordering rate of TTEs based on those elements. And what you can see is, irrespective of the specifics of those graphs, is that you can establish a nice pre-intervention trend. You have a bit of noise variation here from time to time, but overall you can see, if I would plot a line here, you can see a relatively flat pre-intervention trend. You can see an immediate drop in the number of TTEs that was performed from the compared to the pre-intervention period. And then there appears to be a sustained change, a decrease over time as T progresses and the intervention was implemented. So overall, the authors, based on those findings, the findings suggested to the authors that, doing an education exercise, structuring a quality improvement initiative the way they've done it, with lectures, with pocket cards, and with bi-weekly, email follow-up, appears to be an effective way of reducing the number of inappropriate TTEs in their setting. So this is just to finish off with my presentation. So we do know that randomized control trials are the gold standards to infer causality and to inform practice. I mentioned a few elements. There are problems with costs. There are problems with the time sensitivity. So it might simply not be feasible or viable to conduct a randomized control trial for a small quality improvement initiatives. There are significant biases with randomized control trials if they are not conducted appropriately. Think about allocation, blinding, conduct, reporting. And we can now see that there has been a shift away from randomized control trials, much more into causal experimental study designs, which can also establish a causal link. And based on the data that already is collected routinely in healthcare systems, there's a huge window of opportunity to actually apply those methodologies to study causal effects of whatever happens in the healthcare system. And this is just me telling you that, but you don't have to trust me. But in 2021, the Nobel Prize Committee awarded the Nobel Prize in Economics to Joshua Angrist and Guido Imbens, who are based in the United States, in Harvard and in Stanford, and they have actually been pushing or revolutionizing this idea of using causal experimental study designs. And the methodologies haven't been around for very long. But presenting them with the Nobel Prize in Economics, I think, gives substantial weight to this idea of going beyond randomized control trials. But of course, ultimately, what we need is investments in data infrastructure, analytical capability, and knowledge amongst clinicians. And I think, you can be a fantastic clinician, but I think what we need is people who can combine, the the clinical knowledge and the expertise in medicine and cardiovascular medicine with sort of analytical capabilities to really bridge the gap between, the medicine, the decision making on the ground, and the decision making that happens at a managerial and higher level within government. So I think with that in mind, I'm just coming to an end here. I'm just highlighting out of self-interest that at the LSE we do have 2 executive programs actually, which might be quite interesting to you, which focus on developing those skills for methodologies to derive causal estimations. One specifically focused on cardiovascular sciences, and the other one that I'm the program director of in collaboration with the National Institute for Health and Care Excellence. But with that in mind, I think I would just stop here, and over to you, Anna.
Okay, thank you. Oh, it was a wonderful presentation, but of course this is complex. Regarding your presentation, I think we can draw that for analyzing, for instance, the health results or the results of our intervention and outcomes, we should apply the same principles and statistics and metrics that we use for an RCT. So the statistics are not different. That's why sometimes we think it's easier, but it's not easy, because to draw conclusions from observational studies, like following the practice of a hospital or following a medical condition, it may be hard, and you have to apply statistics and to draw important conclusions from that. Is it so? It's you apply normal statistics like an RCT or observational study, and to see if practices are okay and if there is improvement in outcomes. And the second question, very, very direct. Is it in UK? I think in the Nordic countries like Sweden, it is obligatory to collect all data from patients that are public patients. So it's not an option to do registries, because registry is natural in those countries. They have to register everything. And then I don't know if in the UK it's like that, or just is it obligatory, this kind of report to the authorities and policymakers, and just to draw, improve the programs, and do you think this should happen?
Yeah, thank you so much for both questions, which I think are really important. So for your first point, I think we should not forget doing an observational study. Just looking at what happens in a hospital gives you an association, perhaps, but it does not give you causality. So we will have to use statistical methodologies to actually, overcome those issues. I mean, of course, if you work in medicine, I mean, you're an expert in your field, but the papers, if you look into research that is being published in the medical field, you either have RCTs or you have very often observational studies giving an association. And what you do as an author is to write a nice narrative that gives the reader the feeling that this is a causal relationship. And I think there's a lot of work to be done still to actually go beyond this association research. And I think in an ideal world, you might be able to use observational research to understand what is happening in the system over time, to identify these evidence practice gaps. And those observational research can then inform the quality improvement initiatives that you are perhaps implementing or designing in direct response to the problems that you observe. But I think to evaluate the effectiveness of an intervention, we have to go a little bit further than that and apply the correct methodologies. But in some instances, it might not be feasible. And one element is if you don't have the right data to do so, for example. And with regards to your second point, I think I mean, every country is really different. And I mentioned, and you mentioned the Nordic countries, which I think are renowned to be sort of the front runners of linking data from, what happens to patients in the hospital, linking them to workforce data, so you can really, I mean, you get a fantastic overview of what happens to individuals on their care pathways and how that influences the wider, them much wider than just the clinical outcome that you're interested in. In the UK, I think there's a little bit of fragmentation. So depending on the clinical area, you do have registries that have been set up to collect much more granular information to the information that is routinely collected for every NHS patient, for example, when they come to the hospital. We know what's being done to them, what their diagnosis is, and a bit of information on their demographics, but that's about it. And these registries give you a much more detailed information. But of course, one problem we have in England is sort of the linkage between what happens in the hospital sector to what happens in primary care. And as you imagine, in cardiovascular medicine, secondary prevention, these things are so important. How does one thing influences the other thing? And when we think about outcome measurement, we don't just want to look at, 30-day mortality, for example, in patients. So a lot of work to be done. Other systems, trust me, are much worse. I'm working in Germany, for example. It's an absolute disaster. We have even more fragmentation. It's almost impossible to get a picture of what's happening across the entire healthcare system because it's all broken down into different insurers, and it's a disaster. Yeah.
Well, thank you very much, Rocco. I think it was very important with your session, your presentation, and thank you very much for coming.
No, thank you.
It was a real pleasure to have you here, and we'll have in the future, hopefully.
Thank you so much. Hopefully in person. Yeah.
Yes, hopefully in person.
Yes, thank you.
So we'll move directly to the next speaker, and I would like to present Stefan Peterson. He's a professor of cardiovascular medicine at the William Harvey Research Institute in Queen Mary University in London, and he's the clinical director for research at Bart's Heart Center. He's also the cardiovascular program director of the UCL Partners at the Academic Medical Center. He's, and this is very important, the president-elect of the European Society of Cardiology, the ACVI, European Association of Cardiovascular Imaging. He's a chair of Task Force of Value-Based Healthcare, and I'd like to say that I have an honor to be his friend, and we worked together since 10 years ago when he founded, as a chair, the first CMR certification. And I was in that group. I'm very honored for that. So I was very happy. And then this system was copied for all the other modalities. So I think it's due to your work, and it was a very good. So he's a known researcher, as everyone knows, and we are, of course, I'm very happy. We are very happy to have him here, talking of this important topic. Stefan, it's your.
Thank you very much, Anna, for this kind introduction. I think you've put together a really interesting session today, so I really enjoyed listening to it, even though my Portuguese is non-existent, but the slides were certainly very interesting of the second speaker also. Can you see the slides in the right way, or are they presenting in a, okay, good. So yeah, so I'll pick up a few of the threads that you've heard about earlier, but then focus a little bit on economic evaluations related to cardiac imaging. This is my disclosure, similar to what Rocco has shown earlier. I provide consultancy to Circle Cardiovascular Imaging, but I don't particularly think that impacts the talk. Anna, you presented already earlier.
Stefan, sorry, can you put it in a presentation mode, because
so it is not an, okay, so that's what I wanted to know earlier, because I can see it in presentation mode. But,
never mind. So you can.
No, it's better if you see it properly. Any ideas how I do this?
I think you just have to do that in your computer.
Just go out, and in again with the file, because I think, yeah. Now try to share again.
Start over.
Because the slide was not moving. And
I have
now
this.
full screen presentation mode. Yeah, there we go.
Is that better?
Oh, no.
It's still on with the small slides aside.
Because I can see it in the correct way. So I don't know. This is weird.
Can you try to move the slide down in this mode? Just move to the next slide.
Well, I am moving. Can you not see it moving?
No, it's not moving.
No, it's not moving.
Okay.
So why don't you keep it?
I will try something different because I shared only the PowerPoint presentation. I'm now sharing my screen. I don't know whether that makes a difference.
No, it's okay.
No, it's okay.
Now it's okay.
Yes.
Yeah, that's good.
You just have to go to the first.
So I'm just going to pick up the thread, Anna, that you've talked about this important paper by Michael Porter from the New England Journal of Medicine, which basically defines what value in health and healthcare is as health outcomes per dollar spent, and that the goal of healthcare delivery is to achieve high value for patients. And what this suggests is the need to improve by comparing new interventions to current practice and to invest where greatest health outcomes are achieved. I think all of this is quite intuitive and logical, so I don't really need to spend much more time on this. So what I would like to do in the time that I've got left is to talk a little bit about what health economics actually is, how you might go about building a health economic model, and what the outputs of health economic models are. And then I'll particularly give you 3 examples of manuscripts that I've been involved with that are doing an economic evaluation of the CMR diagnostic pathway, and with 3 slightly different approaches. One uses best evidence from the literature based on systematic reviews and meta-analysis. One is, that's actually the one I wasn't involved with, that uses a randomized controlled trial as the basis of doing an economic evaluation. And then the third one uses the EuroCMR registry and the SPINS registry with patient level data to perform an economic evaluation. So what is health economics? It's basically economics applied to health and healthcare, which has some peculiarities about it. And it's concerned with scarcity and allocation of finite goods. And for example, that involves people, time, beds, tests, and drugs. And health economics asks questions like what goods or services shall we produce or provide, and how shall we produce them, and who will receive them. So it essentially is economics applied to health and healthcare, as I said. Economic evaluation is a term that is the assessment of costs and effects of a healthcare intervention compared to alternatives. And I just pause here on that sentence because that's really important to understand, that you're looking at both costs and effects, unlike what we've heard earlier, that randomized controlled trials, for example, are often just looking at the effectiveness. Can something work, as opposed to does it work and how does it actually work and how much does it cost us? So important is an economic evaluation looks at costs and effects, and it doesn't look at just one intervention. It usually looks at an intervention compared to at least one alternative. But actually, unlike randomized controlled trials, an economic evaluation can actually model many, many alternatives or strategies. And I'll show you that in the examples later. And the goal of an economic evaluation is to inform efficient choices in healthcare. And I'm sure you've all heard the term opportunity cost, given that there is not an infinite amount of money available in healthcare systems. So it's always has limited resources. When you then invest resources in one area, there's usually a loss of opportunity in using this particular resource elsewhere, and that's called an opportunity cost. The analysis is according typically to the perspective of the decision maker. And if you do an economic evaluation from, say, a hospital perspective, you might want to know, well, if I'm investing into a cardiac MR service, is that actually better for the hospital compared to buying another 3 echo machines? So that's then the perspective from the hospital. But if you are interested at a healthcare level system, which is the better test in patients with stable chest pain, that's a different approach to making to basically valuing which test is better. So it really is important to think about what the perspective is. The comparative analysis, so an economic evaluation is a comparative analysis to obtain the cost per health gain. And there is basically cost per quality of life years, something that you'll hear about. So after going through what health economics is, let's think about building a health economic model. Cost effectiveness analysis in the United Kingdom is typically carried out by agencies such as the National Institute for Health and Care Excellence, or NICE. And that is particularly true as really, if you do economic evaluations properly, cost effectiveness analysis, it's quite complicated, complex, and it's not something that you can do on the back of your envelope. I think that's one of the key messages I'd like to leave you with. It's not just adding a few pounds and the effectiveness, and then you have a cost effectiveness analysis. The health gain measures we're using are usually quality adjusted life years, or QALYs, and I'll explain a little bit better what that is in a minute. A QALY, the advantage is that it's a generic measure that supports decision-making across clinical specialties and pathways. The problem is if you have effectiveness measures, I don't know, one is improvement in pain scale, and another one is improving longevity, so extending lifespan. How do you actually compare these? And by using quality adjusted life years, it's a way of being able to compare different treatments, diagnostic pathways with the same effectiveness measure. In the United Kingdom, we've got an accepted threshold that one is willing to pay. A cost per health gain in the UK is usually about 20 to 30,000 pounds per QALY. So if something is more expensive than that to gain one quality of life year, then it's considered not cost effective. So here are 4 examples of full economic evaluations: cost minimization analysis, cost benefit analysis, cost effectiveness analysis, and cost utility analysis. I'll give you one example of a cost minimization analysis later in cardiac imaging. Cost effectiveness analysis and cost utility analysis is sometimes used interchangeably, but in principle, if you're using as your health outcome quality adjusted life years, then it's called a cost utility analysis. And the reporting of the results is a cost per QALY. So what are quality adjusted life years? Health-related quality of life, if you have an example, you think about 80% of normal. So I might today feel 80% of what I would consider absolutely normal for my age. And if I have that quality of life for 2 years, then you can plot it like this graphically. And if you time 2 years times 80% or 0.8, then you have 1.6 quality of adjusted life years. And you can imagine that you might actually live for 4 years at a quality of life that's measured at 40% of normal, or 0.4, and you plot it like this, you also get 1.6 quality adjusted life years. So you've got comparable effectiveness, essentially, even though you might have a personal preference to say, well, I'd rather live 4 years with 40% quality of life, or you might say, actually, no, I prefer better quality of life, and I accept that I might only have 2 years to live. But if you're taking the QALYs, they are exactly the same at 1.6 QALYs. So here I'm giving you an illustration of healthcare resource use, and it really is pretty much on the left-hand side, you've got the numbers from the healthcare related groups, or sometimes called DRGs, diagnostic related groupings, which is how hospitals are often paid. Certainly in the UK, we are paid like this, HRG. If you do a cardiac MRI scan for chest pain, which requires contrast administration, you get £361 for the cardiac MR scan and £20 for the imaging reporting fee. So in total, £381. And that's based on some costings the NHS has done or does every few years called NHS reference costs, where they try and work out how much does it on average for a good, efficient hospital cost to provide a cardiac MR scan in this setting. Now, if I'm thinking in our hospital at Bath, say, but these are made up numbers, we need for this scan that takes about 40 minutes, 50 minutes of CMR technician time at £1 per minute. So that costs £50 because the technician needs to prepare the patient, get the patient into the scanner. Then you pay, say, £6.25 per minute for 40 minutes to use the CMR scanner, because obviously there's an installation cost, a running cost of a CMR scanner. And you need to provide, to give a contrast agent, which costs, say, £25. And then you have the radiologist or the clinician cardiologist reporting, and it might take the physician 25 minutes to report the scan at £2 per minute. That would be £50. So you have actually a cost of £375, which is fairly similar to what the HRG cost would cover. So at least here you would run at a small profit margin if you did lots of these scans. But how about if this is sort of an experimental thought, if you introduced artificial intelligence that could replace that would maybe negate the need for giving contrast in chest pain patients and give you the same diagnostic information. Then in the UK, if you don't give contrast, you only get £273 for a cardiac MR scan, according to the HRG. You still get your £20 imaging reporting fee at a total cost of £293. If you think an AI tool can now shorten the CMR scan to 25 minutes because you don't need to give the contrast anymore, you're saving the cost of the contrast agent, you're saving cardiac MR scan time, and that leads to a reduction in the fee. And the CMR technician also only needs 35 minutes now, including preparation time of the patient. So that's £35. And the imaging reporting fee, because you don't have to look at the contrast images anymore, would reduce to, say, £30. So you would be able to provide this scan at £221. And you would actually make a bigger profit here. So this is just an example of how we are paid for cardiac MR and how a hospital can work out how much actually does it cost them to provide a cardiac MR scan. So how about the outputs of health economic models? This is a really important slide and often referred to as the cost effectiveness plane. And I'll spend a little bit of time here just to explain to you what we're actually looking at. So your x-axis and your y-axis plot the delta effectiveness or the incremental effectiveness and the incremental cost or delta cost of a new strategy compared to the standard of care, which would be 0, because that is a fixed cost and not a delta cost and a fixed effectiveness that you have established for standard of care. So this implies that any dot that you might find here is a comparison between alternative strategies, in this case here against the standard of care. And you have the northeast, the northwest plot, and the southwest and the southeast parts of this cost effectiveness plane. Let's start with the southeast. So here you would have an intervention compared to standard of care that is less costly, but more effective. So this means that the new intervention compared to standard of care is actually logical that you should be using that because the intervention dominates the standard of care. It's more effective and less costly. So it's a no-brainer, and you don't really need to do a full economic evaluation. On the other hand, if you have a new intervention that is more costly and less effective, again, it's a no-brainer, and you don't really need to do a full economic evaluation because the new intervention is dominated and worse compared to standard of care. The interesting ones are these areas in the northeast and the southwest, where there's a trade-off, where you have a more effective, in the northeast quadrant, you've got a more effective strategy, but you have it's also more costly. So you need to work out whether it's cost effective. And this is where full economic evaluations can be really helpful. And the same with the southwest quadrant, where you might say, well, compared to standard of care, I have a strategy that is less costly, but also less effective. So you want to know, is this a cost-effective way? And what you can see here dotted is the line, the willingness to pay threshold. This is in the United Kingdom, I've mentioned, often considered to be about £30,000 per quality adjusted life year. So if your strategy is below this incremental cost, this willingness to pay threshold, then you consider this cost effective. If it's above it, because it's more costly for gaining very little effectiveness, then it's not considered cost effective. And the same in the Southwest quadrant, you might be happy if it's much less costly, but you're losing very little effectiveness. So you're in this quadrant here, still under the effectiveness, then it's cost effective. But if you're up here, then you're losing too much effectiveness for saving costs. So it's not considered cost effective. So I hope that that makes sense. And this term of the ICER, or incremental cost effectiveness ratio, is important when you're comparing new strategies compared to standard of care. If your incremental cost effectiveness ratio is below your willingness to pay threshold, then it's considered cost effective. And you should replace it, standard of care with the new strategy. If it's more expensive than the willingness to pay threshold, you stick with your standard of care. So here is a complicated slide, and it's nothing to do with cardiac imaging, but it's a nice one that I found from a paper that basically is in type 2 diabetes. But the intervention and what you're comparing is actually sort of not important, what I want to show you. Again, you can see we've got this cost effectiveness plane here, with the red lines being the sort of x-axis and the y-axis through the intersection. So your standard of care that you're comparing against is in this cross here, 0 incremental quality, 0 incremental cost. And you can see that for this new intervention, when you're testing it multiple times in a model, it's almost always below the the willingness to pay threshold. So it looks as if mostly this intervention is cost effective. Certainly, if you increase the quality to 30,000, this is steeper threshold, more dots lie underneath it, and it looks like it's cost effective. So there's a better way, maybe an easier way to plot this. When you plot the willingness to pay per quality of adjusted life years gained against the probability that your new strategy is cost effective when compared to the standard of care. And in this case that I've shown you, if you plotted the number of dots, you can work out the probability that something is cost effective. And in this case, the new strategy would be 87% likely cost effective at a willingness to pay threshold of 20,000. If you're willing to pay 30,000 per quality gained, then even 92% probability of being cost effective. And here is a completely different example again. This is to do with blood thinners and atrial fibrillation, but actually I don't want to distract and focus too much on what this study investigates. It just shows you that you can have also these acceptability curves for multiple interventions, not just for 2. So here you can see 1, 2, 3, 4, 5 different strategies compared. And what you can see is that up to $20,000 roughly per quality adjusted life year, if you're only willing to pay up to $20,000, then in this case, warfarin is the most cost effective. And after that, dabigatran, 150 milligrams, happens to be the most cost effective strategy, whereas all the other strategy investigated here never really become the most cost effective strategy. So let's focus now on cardiac imaging and the evidence generation for the economic evaluation. I wanted to give you 3 examples. The first one was a cost effectiveness analysis just based on literature, including systematic reviews and meta-analysis. It was led by Tessa Genders and Miriam Huning. And I think I've given you this literature to read. So I'm not going to go into too much detail other than summarizing that this study wanted to look at highlighted the uncertainty regarding the optimal imaging strategy for patients with stable chest pain. and it wanted to determine the cost effectiveness of different strategies from 3 different perspectives: the UK perspective, a US perspective, and the Netherlands perspective. And decision modeling was used for short-term and long-term outcomes. And the overall finding was that cost-effective strategies in all countries were found when the first test was coronary CT angiography. And I just want to show you a little bit the complexity of modeling these. So here on the very left-hand side, you have your study population, a typical patient with stable chest pain and a low to intermediate probability of having coronary artery disease. And then you have this blue square, which is a decision node in a decision tree, which says, I'm now deciding what I do with this patient. Either I can do no imaging, I send this patient for a coronary CT angiogram, or for a cardiac MR scan, or for a SPECT scan, or for an echocardiogram, or I go directly for invasive coronary angiogram. So what you can see here is, in a model, I'm not limited by the number of strategies I can test out. In a randomized controlled trial, it would be really difficult to afford a trial that has 8 different arms in your randomized controlled trial. So here, a decision, you make a decision which test should the patient have first. And then you can see these round circles. These are chance nodes. And to chance nodes, there's always probabilities attached. And let's look at the coronary CT angiogram. So you might, after having done and having the result of the CT coronary angiogram, still send the patient for a CMR scan. In this case, this is likely to happen at 40% likelihood. You might decide, I've got all the information needed, I don't need any further testing. And that likelihood is allocated at 20% probability here. Or you say, after the CT, I actually sent the patient for a SPECT scan, a 30% probability has been assigned here. And an echocardiogram is with the rest of the probability. And these probabilities always have to add up to 1. You need to have a probability of 100% of all of these options together. So here, 0.2 plus 0.4 plus 0.3 is 0.9, 90%. So echo here with this asterisk is basically 10%. It's the remaining probability not used here. So this is basically what we started off with. The decision tree starts off with the decision node and then with chance nodes and probabilities assigned. And then basically the longer term events you model with a Markov model. And we had 3 different health states. The first one is basically patients who are still alive and have not had a coronary event, are in the health state alive without having had a coronary event. And you might stay in this circle for 1 year, for the next year, for another year. And then maybe after 5 years, you move to the post-myocardial infarction state because you've had a coronary event. And then you might survive another 10 years in the post-MI state before you die. Or you might be well and you die immediately. You don't actually die of a myocardial infarction, you die of something completely different. So these are 3 different health states that help you model the longer term outcome. And in the Genders paper, just to give you a bit of an idea where the data has been coming from that underlies this model. So the cost effectiveness guidelines by country differ between the Netherlands, the UK and the United States. So you need to basically, the economic components are likely, and the perspectives are slightly different, and the willingness to pay thresholds are slightly different between the countries. So you need to sort of see what the guidelines are, how to perform these economic evaluations in the country you're interested in. And then the clinical guidelines might differ by country. So in the United Kingdom, we've got the NICE guidelines, for example. You need to know what the epidemiology of your population is. So look at prevalence and incidences of disease. And that you typically take from the literature from observational studies or registries. You need data on the probabilities of events occurring. And again, you take that usually from the literature, maybe you have it from randomized controlled trials, or you do systematic reviews and meta-analysis to get this data. And the healthcare resource use is something that is often an expert opinion, or sometimes you can take it from the NHS reference values, for example. But again, healthcare resource use might be very country specific. And the cost of healthcare use, again, the NHS does reference costing for us, but otherwise you might have to do some micro costing yourself, relevant and in the context of the country you're interested in. So there's a lot of work that goes into building these models and putting the numbers in. So a second option of doing an economic evaluation is to tag it onto a randomized controlled trial. And the CMARC study is a very famous study that looked into the effectiveness of various strategies investigating people with stable coronary heart disease. And again, here, the objective was to assess the cost effectiveness of management strategies for patients presenting with chest pain and suspected coronary heart disease. And the method was basically using data from the CMARC2 trial to assess this cost effectiveness of various different diagnostic strategies. And it was found that CMR guided care was cost effective overall and across all pretest likelihood subgroups compared to a myocardial perfusion scan, so a nuclear scan, or the NICE guideline approach. And the original CMARC2 trial randomized 1,200 patients into either CMR-guided management, into nuclear cardiology guided management, or followed the NICE guidelines, which is based on the pretest probability to do a cardiac CT scan first in low pretest probability, or to do a stress test in the intermediate probability, or to go for an invasive coronary angiogram in the higher pretest probability. The fourth one I just want to briefly mention is when you do an economic evaluation based on patient-level data analysis. And this elegant study that I was part of used data from the EuroCMR registry and the SPINS registries to do that. And basically wanted to look at the economic consequence of non-adherence to current guidance for the use of FFR measurements. And the method here, if you remember, there were 4 different types of full economic evaluations. Cost minimization was one of them. So this was the approach here, which basically doesn't give you cost per quality adjusted life years. It just gives you cost savings potentially. And this is what you can see here. Karin Moschetti basically had a nice central illustration here to show that the cost savings were larger, illustrated by the sort of darker areas here on the global map in certain countries, like the United Kingdom, compared to the US, for example. And if you're looking particularly at different types of patients, if you had atypical chest pain as opposed to typical chest pain, your cost saving was substantially larger if you used a cardiac MR guided strategy compared to going straight to an invasive coronary angiogram and FFR measurements during the invasive angiogram. So in summary, today we've been introduced to what health economics is, the components of some health economic models, and the meaning of health economic output. And I've shown you 3 pieces at a very high level, but I've given you the studies as reading material with different methods to obtain evidence to inform their health economic evaluation. And I think the take-home message, hopefully for you, is that economic evaluations is important, but it's not a back of the envelope undertaking. So you need experts to do it, and you need good data to inform the model so that the model is actually a fairly good representation of what's going on in the real world. And with that, I'd like to thank people that I've worked with on various economic evaluations, and particularly Ijoma Ochekbu, my health economist, who's also helped me put some of these slides together. And with that, thank you very much. And I'm very happy to take any questions. And thanks again, Anna and Fausto, for inviting me to be part of this exciting session.
Thank you so much, Stefan. It was wonderful, this presentation. I would like to, you did present a very interesting paper that on cost effectiveness on patients with MINOCA and CMR, and the value of doing CMR and changing the therapy and preventing, so saving also money and of course risks. I was expecting you to show that that paper. you want to comment the value of imaging
Yeah,
there?
I mean, I guess I can comment. So, I mean, for people who probably know that cardiac MR has the advantage of being able to image and I guess show you the location and the extent of myocardial infarctions, but also of myocardial edema, for example. So it's now been quite well established in these myocardial infarctions with non-obstructive coronary arteries. So when you have patients that present as a ST elevation myocardial infarction, go to the cath lab, but they don't actually have obstructed coronary arteries. Cardiac MR is a really good test to investigate what's really been happening to these patients, whether it was an embolic infarct, plaque rupture maybe, or whether it is actually myocarditis, a common cause, or any other reason why they might have troponin rise and present as a STEMI. And the cardiac MR scan is pretty obvious that you can basically save downstream costs if you do this test early, even though you may arguably it's an expensive test to do, but actually it really influences patient management downstream for long periods of time. If you imagine that if the default is that you presented with an ST elevation MI, even if you have normal coronaries, that you get put on aspirin, on a statin, etc., lifelong. But actually, if the reason why you presented to the hospital was a myocarditis, and actually aspirin isn't the standard of care for this, nor is a statin if your cholesterol levels are actually, reasonable, you actually have long-term costs and implications on quality of life for patients. So it's quite logical to imagine that then a cardiac MR scan is actually cost-effective in this setting. So I think that's the sort of rationale behind that paper that you refer to, Anna.
Yes, and that's very interesting. So I believe, although you say that we can't do cost-effectiveness analysis or outcomes regarding the use of imaging, of course, because it's always indirect, because in the outcomes we are analyzing conditions and not the means to treat, or we're not analyzing medications or investigations. But anyway, it will influence management and the outcomes, surely. I think this should be an interesting way to looking at cost effectiveness, because there are parameters in the middle, investigation or treatment, that can have impact on the outcome. And CMR, definitely, yes. There are several examples. You agree?
Yeah, no, I mean, I agree. I think the problem is with economic evaluations, I would say, if I'm sort of the devil's advocate, is that they're very context specific. So, you need to do one. If you're interested in working out whether cardiac MR or another imaging modality is cost effective in assessing patients with Minoka presentations, you need to do one for that context. And you need to think about, well, do I do it from a UK perspective or Portuguese perspective or US perspective? And you can't necessarily extrapolate your findings if it's cost effective in the UK to say it's going to be cost effective in the United States, because I mean, I'm sure Minoka is cost effective in other places, but a cost effectiveness analysis is very specific for a particular context and indication. So you'd have to do a lot of economic evaluations, and they're very time consuming to do, to cover everything. And then also things change quite quickly, right? Our methodologies get better. There's a newer scanner. The diagnostic accuracy improves of echo with contrast agents. You name it, things are changing. And then you have to basically do it again, because suddenly your numbers are not up to date anymore. So I guess that's the sort of downside of it. It's a very fast moving field, cardiac imaging. And if you want to always cover all areas with economic evaluations, that is almost impossible.
That's true.
But I think that's why these studies are important. Like the last one that I've shown you that tries to kind of extrapolate it for various countries. It's still not all countries, but it provides you with some reassurance that at least if you're doing cardiac MR in patients with stable chest pain, you usually have cost savings in a lot of countries. And that varies maybe the extent of cost saving, but it applies to quite a lot of countries.
That's it. Okay, thank you so much, Stefan. I don't know if there is any questions. We are running a little late, but if no one wants to add any question, I would thank so much for you being here, and hope next time we'll be in presence. I think Fausto is going to close the session, but for me, thank you very much.
Thank you.
Well, thank you so much. It was a really enlightening session. I hope our students enjoyed it. I really enjoyed it. I really want to thank our foreign colleagues, and it's really always fantastic to have this sharing of your expertise and your knowledge. So, Stefan, really appreciate. We could be here the whole day talking about these issues, but very much conscious of the time. And I really want to thank you for also taking the time to be with us today. It's really very gratifying and very nice to have that sort of support. So thank you for supporting us, and to our students, thank you for being here with us today. I hope you enjoyed. I hope you learned. There's a lot of material also that you can be used to review some of the concepts and to prepare also your work. And I really want to thank Anna also for organizing the session and for all the work that has been putting into this masters. And without further ado, enjoy your weekend. Continue to enjoy discussing these issues that are so important for our medical field and for our understanding and implementing better strategies for healthcare. Thank you so much. Have a nice weekend. Thank you.
Thank you. Bye-bye. Good weekend to everyone.
Bye.
Obrigado, Ana. E obrigado a todos.
Obrigada,
Adeus,
Fausto.
então.
Obrigado.
Obrigada a todos.
Obrigada.
E até amanhã.
See you tomorrow.
See you tomorrow.